Hello, everybody. Welcome back for our Day 2 afternoon session. It's so great to see everybody. I am Olivia Frias from Cincinnati Children's, the patient navigator there. I've been honored to be asked just kind of in the past couple hours to moderate this afternoon, so bear with me. We're going to have a great afternoon, but I'm excited to introduce Eileen McMahon, and I will let you all get settled and start introducing her. So she's a nurse practitioner at Hanneman Fertility Center in Toronto, Ontario, Canada. She graduated from the University of Toronto with a bachelor's and master's degree in nursing, as well as a postmaster's nurse practitioner diploma. She holds a clinical appointment as an adjunct lecturer in the Bloomberg Faculty of Nursing, University of Toronto, and she holds a special certification in prenatal nursing from the Canadian Nurses Association and is a certified sexual assault nurse examiner. Eileen served as a Canadian Fertility and Andrology Society Board of Directors from 2016 to 2021 and was their first nurse president from September 2019 to September 2020. Eileen led a team to build a competency framework and fertility nursing, and this is a joint project between CFAS and ASRM. Eileen has dedicated herself to identify best practices for the delivery of an outstanding health care in an empathetic and inclusive manner. She has a particular interest in fertility preservation. Let's all welcome Eileen.
So thank you for the warm welcome. I'm sorry to be the postprandial talk. Hopefully people will be awake enough. This group of talks were put together to explore the various roles of allied health professionals in oncofertility. And so I was asked to speak about my journey to becoming the first nurse president of a national fertility society. But in doing so, I wanted to focus on the importance of mentorship, because that played a huge role. Also the importance of becoming a board director. I'd also like to present the National Fertility Nursing Competencies. They were jointly led by myself with the Canadian Fertility and Andrology Society, as well as the American Society for Reproductive Medicine. And I'll also provide an overview of oncofertility care in Canada. So in terms of mentorship, I was lucky enough to have many mentors in my life. I'm sure many of you have mentors you can think of that have made a huge difference in your lives, and many of you are mentors for people. And so I just wanted to sort of go over quickly what mentors are. So my talk isn't advancing on my own computer, so I'm just going to use my phone. So essentially, being a mentor, it requires a number of different things, but one of the things would be a generosity of time, which a lot of us don't have. But if we have some extra time and the willingness to impart our knowledge and skills and some enthusiasm for teaching and the success of others, then I think, it makes for good mentors. Being a mentor also has an important influence on your development, professional development, on career guidance, on career choice, particularly in the field of healthcare. And a study published in the Academic Emergency Medicine Education and Training found that mentorship increased mentees' sense of personal accomplishment and self-improvement, and improves quality of care and patient outcomes. Mentorship also benefits both parties, the mentor and the mentee. Mentors often feel a sense of personal satisfaction from helping others, and mentoring can increase personal growth and job satisfaction. I'm just going to close this. So this is part of that article. There are attributes and behaviors of effective mentors and mentees. So a successful mentor is one who's enthusiastic, generous, patient, has a sense of humor, knowledge and competency. Ideally, mentors have a willingness to share personal and professional experiences, and of course impart the knowledge and skills and values. But they also should promote networking opportunities for the mentee and act as advocates. But the mentee also has some responsibilities. So they should demonstrate a willingness to learn, they should display a positive attitude, and have a desire for professional growth and development. And ideally, the goals should be clear by both the mentor and the mentee from the outset, if possible. So I was lucky enough to have a particular mentor that I worked with. She was on the board of the Canadian Fertility and Andrology Society, and I knew about CFAS. I had been to their conferences, I was on the nursing special interest group, but the board seemed sort of out of arm's reach because the board directors were all physicians, lawyers, lab directors, scientists, mostly white men, to be honest. And I wasn't sure that that was a place that I could fit. There were no nurses at all that I had even heard of on that board. But this physician said, you know what, the elections are coming up, you should really apply and see what happens. So why bother sitting on a board? If any of you are thinking of sitting on a board, these are some of the reasons why it's a good idea. So you can develop your own leadership, learn from others. Essentially, having a seat at the table with leaders really puts you in a good position to learn from a number of different people. You can watch how they tackle problems, how they work together, how they carry out tasks, weigh potential risks, how they interact with one another. And the other benefit is it adds credibility to your name. So people see you as someone who is not afraid to take on new things, to take on new responsibilities and new challenges. It really opens some doors for you. The other benefit of joining a board is to establish and grow your network. So you further develop cooperation skills, establish bonds. I've made friends with people I would never have met necessarily had I not joined the board. You can also learn about how other organizations work. So you're seeing it from the inside out in a way that you never would have if you're simply a member of that organization. And you can make a real difference. So it's really rewarding to play a key role in an organization, especially when you can invest the time and energy to put work into it and to tackle issues close to your heart. So a lot of the things I brought to CFAS were nursing related, inclusion, diversity, and so things I'm very proud of. And nurses have unique voices, so we should really be on more boards if possible. So which board should you choose if you are going to join a board? CFAS is kind of a no-brainer for me. It's a national fertility organization. I wanted to influence fertility practice at a national level. And so, but questions you can ask yourself before joining a board: do my goals actually align with the organization and the board? Will my skills, experience, or expertise help increase the impact of the organization and further its mission? And can you really commit the time required to fulfill your legal and fiduciary benefit or responsibilities as a board member? So if it's just to pad your CV, that is not a good enough reason. You actually have to be able to take part and attend all the meetings, which there are quite a few typically, but it's just such a rewarding experience. And so after being encouraged and thinking about it, I did run. This was in September 2015. I wanted to get on, even though I was going to be on mat leave, because it was a great opportunity. Unfortunately, I didn't get on. So I applied, I did not get on. But halfway through my mat leave, I actually got a call saying that one of the board directors took a new position in the organization and that I had the next number of votes, and so would you consider sitting on the board for the half year that's left? So I said, okay, sure, I'll do that. But you know, just like Ginger Rogers, who did everything Fred Astaire did, but backwards and in high heels, I actually felt like I had to really work really hard and prove myself. And so my first meeting, I had a 4-month-old. I remember sitting at the board table the entire day in Montreal, breastfeeding. And I think a lot of people remember that, and some people bring it up still. But you know what, be memorable. That's what you need to be yourself. And I mean, I put my hand up constantly, like clinical practice guideline development, policy development, abstract reviewer, whatever they needed, I put up my hand because I was like, I'm gonna show them what nurses can do. And so at the end of that term, September 2016, I ran for the board again, and I actually did not get on. And that same year, I was thinking about fertility competencies because I'm like, I don't think Canada has any national competencies in fertility nursing. And I looked at other jurisdictions. Some of them had them, but the US actually didn't either. So I started planning some of that. And then I actually got a call from the executive director of CFAS, and he said, you know what, I put in a proposal to the board to have you as a non-voting advisor because of how much work you put in, and because our bylaws actually at CFAS say that you can appoint people who are not represented at the board level, and nursing was not represented. So I said, okay, I'll take it. So I was on the board that year as an advisor, and I actually reached out to ASRM to have them join our nurse competency project, and that went really well. It was really exciting. CFAS and ASRM are similar, except CFAS is a lot smaller. But we hadn't done a lot of things together. We had done some conferences together, but the groups had never actually worked on projects together. So I'm really proud that nurses were the first to do that. And so we worked on these guidelines together, and at the end of that appointment, in September, I believe it was 2018 by then, 2017, I actually ran for the board again. Like, I'm a glutton for punishment. So this was my third time, and I got on. I actually did it. And so I announced that I actually was going to be president when I got on. So that was a big deal too, because there had never been a nurse president of the CFAS. And I think a lot of it was, late night scotch and liquid courage. A lot of the board members and directors said, you know what, you should do it. If anyone could do it, you could do it. I'm like, I'm not sure. But you know what, I went for it, and I'm really glad I did, except I picked a really bad year. A really bad year, because I planned this amazing meeting. So part of the presidency is to plan the annual meeting, the conference, like 3 days worth, plus pre-conference. It was so much work. Kyle was gonna speak, Francesca Duncan was gonna speak. It was like gonna be fantastic, the best one ever, right? And then the WHO declared the pandemic in March of that year. So there was no meeting. And so I had to just focus on, COVID-related things, but we still got lots of work done. And actually, in September of 2020, the fertility nursing competencies were jointly published on the websites of CFAS and ASRM. And so those competencies are available on the websites, and they really, they're a guideline to support consistent practice for nurses working in assisted reproduction. And the plan is to also augment those with specialized standards for individuals participating in assisted reproduction, rights and responsibilities of fertility patients, and also a learning pathway and orientation guideline. But these things take a lot of time, and so I'll sort of briefly show you. It took many more years than I thought, kind of like home renovations. You have these great plans, and then they take a lot longer than expected. But this is sort of the timeline. First formed in 2016, undertook a lit review, explored REI certification through the Canadian Nurses Association, actually. We were told your group is too small, we won't be able to upkeep psychometric testing, so there was no certification option, so this was sort of, at least we'll have some competencies that people can, strive for. We developed a scoping document, submitted it to the CFAS board. We were able to get approval and a budget, which is important. And then again, like I said, in 2017, we joined forces with ASRM. We had many meetings. We consulted with a competency expert. 2018, more meetings, first level review by the ASRM practice committee. They came back and kind of took the wind out of our sails a little bit. They said, this is not fertility specific enough. So we kind of regrouped. We had our expert review things, and we had a second level review after we made it more fertility specific, and they actually liked our document the second time. And then in 2020, it was actually approved by the ASRM Practice Committee and the CFAS Board of Directors. So I know that competencies have been a topic of interest within the nursing and navigator groups here, and I think these core competencies can be easily applied to these groups. Their competencies, the subcategories, and the descriptors are all meant to be used in conjunction with what clinics already have. So they have their own orientation programs and specific practices and guidelines, but these can be used as a sort of an adjunct for people. I'll briefly go through them. So the first core competency is communication. Therapeutic relationships, sort of both between healthcare providers and patients and between healthcare providers themselves within the circle of care. There's also interviewing. That has to do with knowing how to elicit and synthesize accurate and relevant information from people. Teaching, obviously conveying information to patients within, for us, a fertility scope, but for here, an oncofertility scope perhaps. Documentation, documenting such that clinical decision-making, patient safety, confidentiality, and privacy are maintained. Continuity facilitates continuity of care through collaboration. This is huge for oncofertility. Safe and effective nursing care is the second one. So there's standards, knowledge, best practice, and safety. I think that can be applied through any of these areas here. The next one is teaching and education. Again, strategies to provide individualized teaching strategies, instruction, providing relevant information and education, and then pharmacotherapy, ensuring patient understand the uses, side effects, self-administration of medications. And that could be the same with chemotherapy agents. The final one, this was based on the nursing process. You probably, those of you who are nurses, remember from nursing school. So assessment, plan, implementation, evaluation. This is what's drilled into our heads. That's why we mirrored it for this competency as well. And of course, the descriptors attached to all of these I didn't present, but they are quite fertility specific. So I think for this group, these subcategories are more relevant. And then my final part of this talk is about how oncofertility care is provided in Canada. So oncofertility has been a key priority for many nations, including Canada. And the topic has been addressed in national workshops, National Systems Performance Report on AYA actually came out. And it's known that all AYA patients with a diagnosis of cancer should undergo a fertility preservation consultation before treatment. But is that happening? So Charlene Ray, a health research methodology PhD student at McMaster University in Hamilton, did her PhD thesis on metrics for AYA cancer care in Canada. Unfortunately, she found that a considerable majority of cases, 84%, did not attend a fertility consultation within 30 days of diagnosis. And as you can see by the reference, this was she defended this thesis in 2021, so it's not actually very long ago. And when she assessed factors regressed on attending a fertility consult within 30 days of diagnosis for females 15 to 39 years of age, she found that a consult is more likely when fertility risk is moderate or high, when chemotherapy or radiation is required, when the patient is nulliparous, if the patient was diagnosed with cancer after 2015, and I'll talk about why that is. When their age at diagnosis was between 20 and 35, they were more likely to have a consult. And when the patient lived in central or southeast Ontario, they were more likely to have a consult. So what else do we know about oncofertility care in Canada? Well, healthcare in Canada is publicly funded and administered on a provincial or territorial basis. Unfortunately, fertility care is not part of that funding. So it's not fully funded in any of the provinces, but some provinces, 5 of which in fact, offer taxpayer assistance. So Manitoba, Quebec, New Brunswick, partial tax credits, PEI, Prince Edward Island, annual funding for out-of-province assisted reproductive technologies, and that's because PEI doesn't actually have a fertility clinic in-house. And then in Ontario, as of December 2015, which is why we saw the uptake in consults, 1 IVF cycle for anyone under the age of 43 with a health card, as well as people who need to bank eggs or sperm before gonadotoxic treatment get 1 cycle. But it doesn't include medications, it doesn't include storage, And there's people in Canada, in a province, that have no funding at all. So it's not equal access for people. Conceivable Dreams is actually a grassroots organization who advocates for coverage of fertility services in Canada. They were instrumental in getting the Ontario funding in 2015, and they're still hard at work. They commissioned research to assess whether employers provided fertility benefits for people, especially for medications. And they found that the majority of employers do not provide fertility benefits at all. And for those that do, only cover on average up to $3,200. And as you know, that's not enough to cover an IVF cycle in terms of medications. Most of our patients, at least in Canada, ranges from about $4,000 to $8,000 for drugs. So as a result, Conceivable Dreams launched the Fertility Benefits Matter campaign, which involved conversations with the big 5 banks in Canada. And some of those actually have gone on to improve fertility benefits as a result. But there's still more work to do. We also have Fertile Future in Canada. So this is a registered charitable organization that started in 2008 to provide fertility preservation financial support. But they run on donations, and the most support they can give is about $1,000, which, as you know, doesn't cover all that much. So unfortunately, this still places fertility preservation out of reach for many in Canada. And then what about the access? So Canada's vast. I don't know if you've ever been, but you can drive in Ontario for like 3 days or something and still not be out of it. And so there's differential access to specialized fertility care. That certainly limits the access to fertility preservation. Most urban centers have a fertility clinic, but not all of them do fertility preservation. And the northern regions have the least. So again, like Charlene Ray found, Central and Southeast Ontario had the most number of consults, and that's because that's where the clinics are. So virtual care has improved this somewhat, but patients still have to travel long distances for the retrieval, so many just say, I'm not going to. And then, another deficit in Canada is ovarian tissue cryopreservation. So as you can see, the newly published ESHRE guideline on female fertility preservation includes OTC. And in 2019, OTC was no longer considered experimental by ASRM. And both the International Society for Fertility Preservation and the Oncofertility Consortium endorsed that ASRM statement. So, I was CFAS president at the time, and so I worked with the Fertility Preservation Special Interest Group of CFAS to write a position statement about OTC. This was a huge, contentious issue within the society, because most people said, we don't have ready access to OTC in Canada, so how can we make a position statement that it's standard of care? Because then people will say, well, then you have to offer it, and if they don't have the resources or the knowledge skills, how are they going to? So we settled on this language, where we basically said it's no longer experimental, there's promising nature of the technology, but it's not readily available. But then we also added, for it to become more readily available, we recommend that all available resources and expertise are mobilized by key stakeholders throughout Canada. We also encourage provincial health legislatures to cover the associated costs. Well, it's a couple years later, and this still hasn't happened, but at least the position statement's there, and we're hoping that things will improve over time. Maybe something like what you have here, where you can send tissue to a center of excellence for cryopreservation. That may be something we could look at instead of everybody trying to offer it in their own clinics. And then the other part of oncofertility care in Canada, there really is sort of a lack of coordinated services that have been identified. So in 2013, Ron and Holzer called out the challenging nature of the current oncofertility system in Canada to function cohesively. They actually suggested a multidisciplinary framework for resource allocation, patient referral, and established lines of communication. In order to enhance fertility preservation access and availability, they recommended that regional division of Canadian healthcare and fertility resources into catchment areas should be established, as well as federal government body oversight committee. But this is the graphic representation of what they were hoping for. The outer resource circle, that would be things like oncologists, hematologists, family docs, nurse practitioners, et cetera. They felt they could provide patients with educational resources and then refer to the inner circle when required. The inner circle would be the fertility preservation consultants, and especially fertility-specific psychosocial services, which are lacking in a lot of areas as well. And so they would want that inner circle to accept referrals on a timely basis, provide consults, perform fertility preservation procedures where appropriate, or refer to other inner circle groups if they weren't able to offer the service needed. All of which, with seamless feedback between the inner and outer circles. So the overall goals here, seamless integration, predetermined fertility preservation pathways and systems, easy access, emphasis on psychosocial services, and constant evaluation of the services provided. But just this year, Glazer and Schultz expanded on this. In their piece, it's called Barriers to Oncofertility Care Among Female Adolescent Cancer Patients in Canada. They still found, many, many years later, almost 10 years later, despite guidelines recommending otherwise, many adolescents do not receive oncofertility support in Canada, and multi-level barriers exist. Like Ron and Holzer, this group felt that clinical models of care where interdisciplinary roles are defined and referral pathways are established would improve oncofertility services. So, although the suggested actions by Ron and Holzer and Glazer and Schultz were never formally implemented in Canada, many of the recommendations are already carried out, not only by nurses, by patient navigators as well. In 2016, I actually co-wrote an article with 4 advanced practice nurses, 3 of whom were in oncology and myself in fertility, about how the advanced practice nurses improve access to fertility preservation for oncology patients every day. We actually presented a poster on this at the Nurse Practitioner Association of Ontario conference and won 3rd best poster. It highlights many of the things advanced practice nurses do. So collaboration, counsel, advocate, educate, build capacity, coordinate, refer out. For everyone in this room, filling system gaps in care, thank you for all that you do, because I think we really are bridging a lot of the divide and gaps that exist. So in terms of my conclusion, take-home points, essentially, mentorship is a critical strategy of support in development. It benefits both the mentor and the mentee. Joining a board, I really recommend it. It is very time-consuming if you really want to put the effort in, but it's such well-spent time. I've learned so much. I have so many friendships and people I can go to if I have questions. Someone says, I'm wondering if this person is doing this in Vancouver or Halifax, and I'm like, oh, let me just text them. Like, you meet so many people you never would have. You can develop your leadership skills network, learn about other organizations, make a difference. And then, in terms of the competency framework, the goal really is to support consistent practice for fertility nurses. And I think the core competencies that I showed you are adaptable for oncofertility care if you wanted to use them. In Canada, there really is room to improve oncofertility support. I think that's why, we are very supportive. This Oncofertility Consortium is a huge resource, motivating for us. But nurses and patient navigators often fill the system gaps and go over and above to provide exemplary care. So I'm really happy to be part of that. These are just some of the references. And then if you ever wanted to contact me, the program says that I'm at Mount Sinai Fertility. I was there for 12 years, but recently, pandemic, reevaluate your life. I made a big move. I left the hospital system and I'm in private practice. So I'm at Hannum Fertility now. Open to any questions if you have them.
Thank you so much for speaking and presenting. Really loved it. James Ludeman, I'm a fertility preservation nurse navigator at Children's Healthcare of Atlanta. First, I wanted to say I loved your article that you co-wrote, and I cited it in some scholarship applications for grad school. Yeah. And I think I won some scholarships writing about that, so really loved that. My question is, you shared about there's sporadic coverage for fertility preservation in Canada. I guess I have a twofold question. Number one, does that also apply in Ontario, for example, the one round of egg freezing or sperm banking for patients that are younger, like under 20? And then my second question is related to some of the barriers to comprehensive fertility care. What is your understanding from Glazer and Schultz, like what some of the top ones are? Is it mostly financial? Is it mostly kind of the models of care and the referral and the cancer program, or yes, all of the above?
So if the person has a health card in Ontario and they can produce sperm or have eggs that you can, grow in vivo, then they are covered for one cycle, one sperm bank visit. Doesn't cover the medications or the storage. If they're pre-pubertal, that is a big question mark. Some provinces, you can sort of hide it under an ovarian biopsy for other reasons, or testicular tissue biopsy at the time of other exams under anesthesia, that sort of thing. But the Ontario Fertility Program itself, which is the funding for the fertility care, doesn't cover those things. In terms of the article, they didn't seem to highlight one over the other, but certainly finances are a barrier. And they really, like Ron and Holzer feel, there needs to be almost a federal oversight so that there isn't such differential access. It's really unfair that if you're born in PEI and you get cancer, you're very unlikely to have oncofertility care, versus you're born in Montreal at the Saint-Justine, you can get your tissue cryopreserved. It's really unfair, and so I think we really need to work better nationally to have better access, even if you can just have the actual procedure for the tissue at your local hospital. Sick Kids in Toronto, sometimes they do it, but there isn't always a place for them to send the tissue for processing or storage. But I think there's lots of great kids centers in Canada that if we could maybe collaborate somehow, maybe send the tissue to Kyle, we could really get more kids a better future in terms of their own biologic fertility. Thank you very much.